So just diving right in, I want to talk about the purpose of clinical research, which I will define as to understand and to find solutions for clinical problems through real-world data. And of course, for this particular talk and discussion, the clinical problem of interest is multiple sclerosis, MS, which we know is associated with neurological associated disability, sensory cognitive disability and dysfunction, as well as ambulatory disability. And so to this end, a better understanding and treating and resolving this clinical problem of MS, we have two approaches, two broad categories of clinical studies. So we have observational studies and we have interventional studies. And so I'll divide my remarks by talking about each of these individually. So we'll first begin by discussing observational studies. So if observational studies had a motto, or if we had a motto for observational studies, it would be, until we look, we won't know. And so by that, I mean that observational studies concern themselves with the who, what, when, where, and why of this clinical problem of MS. Who gets MS? What is MS? When does it occur? Which regions of the brain or what part of the body is affected? And of course, why, what causes MS? And the approach of observational studies is really to look at trends in all sorts of data. So clinical presentation data, MRI scans, biological samples such as blood and CSF, as well as survey data. So information that's provided by consenting participants in the form of surveys. So let's look at a couple of examples very briefly. Let's this question of who gets MS. And of course, that's a complex question, but looking at this study that was done in 1979, looking at ethnicity, this was a study conducted with a sample of World War II veterans and data collected from these individuals. And individuals who self-identified as being either white, so we have white women, white men, and Black men. And from these individuals, looking at the data and diagnostic data that was provided, the authors calculated the ratio or proportion of individuals who had MS to those who did not. And what we see from these numbers here is that white women, by and large, had a significantly greater proportion of those who had MS versus not MS. And so it's from observational studies like these that you get an understanding of the clinical problem. So in this case, and studies like this, early on, it was believed that MS was a lot more common among white identifying people, particularly white women. However, more recent studies, and this was a study done in 2013, helped to nuance and modify that view to give us a better understanding of how MS would work. And so here we see that in this study group of patients from Southern California, again, looking at ethnicity, so Black Americans, white Americans, and Latin American identifying individuals, that the incidence of MS paints a bit of a different picture, doesn't it? So we see the greatest incidence among Black Americans, and with white Americans not being about a little over half of the incidence among Black Americans. And so the main point I'm trying to make here is that we need multiple studies that are conducted by different groups over time to really clarify narratives and really get a clear understanding of how our clinical problem like MS works. Another question, so what happens during MS to the brain? And so, over time, we understand that MS is associated by its name with these lesions, these multiple sclerotic plaques that are present on the brain, different regions of the brain and the spinal cord. Through additional observational studies, we've come to appreciate that there's also this loss of tissue that's accelerated among MS patients over time. So the central nervous system atrophy, as depicted in this picture here. And when you combine a lot of these studies, you start to get a more comprehensive view of how our clinical problem of MS looks. So over time, when we combine the understanding of what is MS and how it manifests in the brain with ethnicity and who gets MS, we've realized through multiple studies over the past 25 years or so that there's this severity disparity among Black African diasporic identifying patients. So that looks like double the rate of tissue atrophy over time, double the number of lesions that will develop and the volume, the size of those lesions. And associated with these pathological manifestations, an increased, more rapid rate of disability on average, according to these studies that were done over the past 25 years. I'm just depicting and naming a few of these studies that looked at these particular measures. And so we see that as we get more information, additional answers or results beget additional questions. And so the question of why is this happening has come up, and studies such as what I'm about to present here, done by Gray and Roncall et al., recently try to address that. And so this group looked at the potential influence of social and behavioral factors on this severity disparity. So they looked at individuals who consented to participate from 10 partnering MS centers, identifying either Black or white. And they collected additional data such as smoking status, years of education, body mass index, employment status, insurance type, etc., as social or behavioral associated factors that could influence severity, and looked at these factors and how they modified things like disability scores, brain lesions, and CNS atrophy, which had this output of being more severe among Black identifying patients compared to white patients. However, even as they controlled for the influence of these factors, what was borne out was that these factors, even though they could influence some of these factors, like the brain lesions or the disability scores, these factors didn't completely account for this discrepancy or this disparity present between these two groups, between Black and white Americans with MS. So, as I mentioned, as we find more information, we need to do additional studies to clarify and fill in some of the gaps that we don't yet have understanding regarding. And so, in addition to social factors, some groups look at biological samples. So, for instance, we know that white blood cells of the immune system play an important role in driving the disease processes behind MS. So these are pictures of different types of white blood cells that are circulating in your bloodstream and within your tissues, et cetera, that usually survey your body for pathogens such as viruses and bacteria, et cetera. And in the case of MS, these white blood cells traffic from the blood into the central nervous system, where they may elicit damage, such as lesions and atrophy of the CNS tissue. So this is an area that I'm particularly interested in, and I've conducted some work on, and I'm going to continue to pursue in the future. And so for what was published not too long ago, recruited individuals who consented to participate who had MS or didn't have MS that self-identified as being either Black, of the Black African diaspora or Latin American ethnicity, or white, and stratified according to ethnicity. I collected blood from consenting participants and quantified the number of key white blood cell subsets that could go on to elicit damage. What I found was that plasmablast levels, so these plasma cells here, were double approximately in number and frequency among the Black African diasporic or Latin American cohort compared to the white cohort. And interestingly, this difference is really present only among those with MS, but not those who did not have MS. And so this is an active area of investigation in the field. So interventional studies. If interventional studies had a motto, it would be that, well, we've got to do something. We have to intervene, not just observe. And really, at its core, it's the effects of a particular intervention on study participants that's at the heart of an interventional study. So similarly, studies look for trends in clinical trial data. So MRI scans, biological samples, survey data, as before. And so examples of predefined clinical trial endpoints for MS would be things like measuring the rate of relapses in a study sample over the course of a study period, the number of lesions, the size of the lesions, et cetera. And as a result of really these studies over the past 25 years or so, we've had a number of major advancements in treating MS, primarily in influencing this peripheral white blood cell component. So in the 90s and the aughts, we had the glutamate acetate, Copaxone, and the interferons, which had a bunch of effects, but generally promoted anti-inflammatory properties and had modest efficacy. Later on, we had biologics such as Tysabri, which blocked the trafficking of the particular white blood cells into the brain and spinal cord. We also have these newer depletion therapies such as Ocrevus and ofatumumab and Rituxan that deplete either B cells, or Lemtrada, which depletes both B cells and T cells. And these are very high efficacy in terms of limiting disease activity. Just briefly touching on a general definition of types of clinical trials according to phases that you may be familiar with. So promising drug candidates for the first time that they are used in human participants are phase 1 trials, usually with less than 100 participants, really looking for evidence of safety in the use of humans, where we look for assessing just dose, safety, tolerability in the context of human biology. Phase 2, we increase the number of participants, now looking for evidence of effectiveness in the condition, and participants are also monitored for safety, for toxicity. Phase 3, increase the number even more, and this is meant to be a controlled sort of snapshot of how the therapy may work in the actual real-world population. And so the study participants in the phase 3 trial are meant to mirror the real-world patient population to the best extent possible. Now, if the drug is approved, then phase 4 trials, follow-up trials, are also conducted. So the size of these trials can range, but really these are important because you're trying to capture a sense of how the therapy would interact with MS in the real world true population that we're trying to treat. And so this is a key phase as well, even though it's not usually talked about. I just wanted to highlight that study participants among these key phase 3 and phase 4 trials tend to be disproportionately, to a great extent, identifying as white. And so I'm just highlighting here that if you average number of participants for a number of phase 3 and phase 4 trials, you get about 90%, 92% identifying as white, and really a paucity, so less, 3% as Black or Latin American. And this is important because there's some literature out there that suggests that there is a suboptimal impact of particular therapies, namely in the interferons. And so this particular study by Cree et al. In 2021 looked retrospectively at clinical trial data from the Ocrevus trial, phase 3 trials, which had a rebif interferon 1 alpha arm. And they found that there was greater MRI activity in Black study participants who were on rebif compared to white study participants who were on rebif during that trial. One caveat is this particular study and others that allude to this suboptimal potential impact have a small number of participants. So it's an area of further investigation to really determine what the real world experience is like for Black patients who are on interferons. So finally, I just want to make this point that, as I've been alluding to, who participates in clinical research, whether observational or interventional, really matters. So MS is complex. The manifestation and the course of MS can vary for different people. And so if we look at this circle that represents all of the people in the world with MS, so approximately 3 million or so, this represents a range of individuals, lifestyles, experiences, smokers, non-smokers, men, women, different ethnicities, different countries, different diets, etc. This tiny circle that just popped up on the screen represents people, the limited number of people in a particular MS study, right? A very tiny fraction that really is not able to capture the full range of what MS truly is and how it truly affects everyone. So we can't study all the factors for everyone and everything about MS with any particular study, one study. So representative study samples do matter, and how we interpret the trends in light of those differences matters. And we need multiple studies to be conducted over time by different groups to get a true representation of what MS is, who it affects, and how we can best intervene. So to close off, just some key points, true of both observational and interventional studies. We need both types, multiple types of clinical research studies to understand and treat MS. In both cases, we look at data that's collected, different types of data that's collected from consenting participants and interpreting trends within that data. And once again, inclusive groups, inclusive study samples are important for truly understanding and treating MS.